Picture this. You are standing in the bathroom, feeling a heavy pressure that screams, "It is right there," yet nothing moves no matter how long you wait. Thousands of aging adults face this exact gridlock every single week, and for a startling number, it escalates into a frantic trip to the emergency room. When that sensation of a brick wall hits, fight the primal urge that almost everyone reaches for first. Do not bear down with explosive force. For anyone past 60, that gut reaction is frequently the trigger that turns a bad moment into a dangerous one. Instead, I will guide you through a carefully ordered ladder of solutions that actually deliver results. We begin with the softest, most supportive techniques and climb steadily toward the very first tool many specialized surgeons keep in their pocket. Stay with me until the final reveal, because the last entry on this ranking is the one that provides the swiftest victory for the largest number of people. But before we dive into the sequence, we need to look at the internal mechanics of why certain fixes rescue you while others leave you stranded. As the meals you eat travel through your large intestine, moisture is steadily pulled out. In a healthy system, this extraction stays perfectly tuned, so the waste exits with a soft, easy shape. But if that waste camps out in the final chamber for too long due to sluggish movement, a fluid deficit, or repeatedly silencing the body's call, the drying process goes into overdrive and the mass transforms into a dense, pebbly obstruction. The encircling muscles grow exhausted and the rectal wall balloons outward, gradually losing its sharp sensitivity to the natural evacuation alarm. Once you cross into the late 50s and beyond, this breakdown occurs with significantly greater frequency for a handful of biological reasons. First, the rhythmic churning of the gut naturally downshifts with the passing years. Second, a huge slice of this demographic takes daily prescriptions that quietly put the brakes on digestion as a side hustle. Think iron tablets, specific opioid pain relievers, calcium channel blockers for blood pressure, and several classes of mood-stabilizing medications. Third, the internal thirst meter dulls over time, meaning hydration levels drop without the person ever feeling a conscious warning. And finally, daily motion decreases. Physical movement is a direct ignition switch for intestinal movement. Stack these four factors together, and you craft a brutal feedback loop. Reduced water and activity breed concrete like stool, which makes elimination a painful battle, which makes a person subconsciously delay the bathroom trip, which leaches even more moisture from the blockage. That is why the real escape hatch involves layering several tactics simultaneously, not just hoping one magic bullet saves the day. Speaking of support, we are pushing hard toward 200,000 subscribers this month. If this material sharpens your understanding, hit that subscribe button right now. It takes just a heartbeat. Let us push forward. Here is a puzzling twist that frequently misleads people. If, on top of this rock-solid obstruction, a sudden gush of watery fluid bursts out, that does not automatically signal that the crisis has cleared itself. Often, the liquid fraction of new stool simply weeps around a stubborn, desiccated plug that remains firmly anchored in place. Medical professionals label this overflow incontinence or paradoxical diarrhea. If that lower belly fullness persists after the liquid episode passes, the core jam is almost certainly still camping there. In this predicament, countless individuals instinctively grab a standard stimulant laxative and then battle confusion when zero progress occurs. The logic is straightforward. Most gut stimulants trigger a mass contraction wave across the entire length of the colon, shoving contents from above. But if the crisis point sits precisely at the final exit, where the mass is already compressed and cemented, ramming from upstream often fails to dislodge the obstacle. Visualize trying to pop a champagne cork by frantically squeezing the middle of the bottle rather than gripping the cork itself. Fiber plays a tricky double role here too. Under normal circumstances, it is your greatest ally. However, if you suddenly flood your system with roughage without a matching flood of water, the bulk swells while the concrete plug at the bottom refuses to budge it. The pressure builds and the misery compounds. This explains why, for a targeted rectal roadblock, locally active solutions tend to rescue you far more efficiently than whole-body approaches. Now, we will stack the options in order of escalating power. We start with the gentlest foundational habits and climb straight to the single most dependable relief mechanism available. Number 7. Strategic warmth and precise fluid timing. Immediately after you roll out of bed, before a single bite of breakfast crosses your lips, drink a full glass of warm, nearly hot water. The thermal shock triggers a neural reflex known as the gastrocolic response, a biological signal that wakes up the entire digestive highway as soon as the stomach receives something. Over the full arc of the day, target roughly 1.5 to 2 liters of total fluid intake, unless your physician has capped your liquids for specific conditions like congestive heart failure or advanced kidney disease. Use the shade of your urine as a dashboard gauge. It should look like pale straw, not dark amber. Coffee and alcoholic beverages do not count toward this hydration tally because they exert a diuretic pull that can actually deepen your dehydration deficit. This practice forms the bedrock. It props up every other intervention on this list, yet standing alone, it usually lacks the speed to break a current blockage today. Number 6. The optimal elimination posture. This tactic costs absolutely nothing and frequently triggers an almost instantaneous improvement as an assistive move. Slide a low footstool or a sturdy stack of reading material about 6 to 8 inches high under your feet so your knees climb noticeably above the line of your hips. Then, angle your torso forward and rest your elbows lightly on your thighs. This maneuver unbends the natural kink between the rectum and the anal canal. In a conventional upright sitting position, that angle pinches like a bent garden hose, obstructing flow. Research into pelvic floor dynamics confirms that this squat-like alignment dramatically cuts the required straining force and optimizes the emptying pathway. Now, we accelerate into the techniques that strike with considerably greater speed. Number 5. Exhale propulsion instead of breath-holding strain. Violent straining feels instinctive, but it is frequently the very act that converts a simple impasse into a vascular crisis, especially beyond age 55. Forceful straining typically involves clamping your airway shut and skyrocketing the internal pressure inside your chest and gut. This is the Valsalva maneuver, and for individuals managing cardiac conditions or fragile blood vessels, it can cross into genuinely unsafe territory. Trade that risky approach for a slow, controlled inhalation. Then, as you release the breath, engage your stomach muscles in a soft, sustained push, much like gently fogging a mirror with pursed lips. Several rounds of these gentle, exhale-driven efforts will frequently outperform a single brutal, vein-popping strain session. Number 4. The abdominal mapping rub. Begin with warmed hands. Trace a slow path starting low on the right side of your belly, sweeping upward toward the ribcage, cutting across the top, descending down the left flank, and finishing low on the left side. This mirrors the natural highway of colonic flow. Use tender circular strokes and maintain the motion for 5 to 10 minutes. The prime windows are first thing upon waking or 20 to 30 minutes after finishing a meal. Many find that committing to this ritual regularly rewires their bowel rhythm over the long haul. Everything from this checkpoint onward operates precisely where the battle is raging. Number 3. The spoonful of liquid gold with citrus. This is the kitchen-based remedy that sparks curiosity. The preparation is simple. 1 teaspoon of cold-pressed extra virgin olive oil blended with the juice squeezed from half a fresh lemon into a glass of comfortably warm water, consumed on an empty stomach early in the morning. A number of folks report noticeable ease, though rigorous clinical data remains sparse. The proposed mechanism suggests the oil lays down a slick film, while the acidic jolt from the lemon gently nudges the gallbladder to contract, which can wake up the downstream plumbing. If you decide to test this, do not stand there waiting for an instant miracle. When it succeeds, the window usually spans 30 to 60 minutes. If you take blood-thinning medication or carry a gallbladder condition diagnosis, run this past your doctor before trying. If the initial 3 rungs have not cracked the blockage open, the next 2 are the ones people most often discuss with their pharmacist or primary care provider. Number 2. Magnesium hydroxide suspension, commonly recognized as milk of magnesia. This agent belongs to the osmotic laxative family. It operates by luring water molecules into the intestinal channel, turning a rock-hard mass into a soft, passable slurry. The standard adult dose on the packaging generally points to 1 or 2 tablespoons, but you must verify the exact manufacturer's guidance on the bottle in your hand. The window of effect swings anywhere from half an hour to 6 hours. This option requires caution or outright avoidance in those with reduced kidney function, and you must check with your physician if you are on heart rhythm medications or tetracycline-class antibiotics. Never use it continuously beyond a single week without a doctor's oversight. Several more instruments deserve a spotlight before we reach the top spot. These are less about acute rescue and more about preventing the nightmare from looping. Stool softeners like docusate sodium do not trigger muscle contractions. Their sole job is to help water and fatty molecules penetrate the hardened mass, softening it from the inside out. They are a common go-to after surgical procedures, for new mothers, and for anyone ordered to avoid physical exertion. The softening effect usually becomes tangible after 1 to 3 days of consistent use. Prunes and their juice, a warm sit soak, and a brief post-meal wander round out the auxiliary toolkit. Prunes pack sorbitol, a sugar alcohol that gently drags moisture into the bowel. A 10 to 15-minute warm pelvic soak unkinks tense sphincter muscles that clamp down from stress and discomfort. And a 15 to 20-minute stroll after eating mechanically jostles the gut into rhythmic motion, often delivering surprisingly rapid results when paired with these other interventions. And now, the top slot. Number 1. Glycerin suppositories. This stands as the option that brings the highest percentage of people the fastest, most predictable relief, and it remains a top-shelf recommendation among colorectal specialists specifically for impactions camped right at the exit. It functions locally, exactly at the site of the blockade. It performs a dual action, drawing moisture into the hard stool to soften it, while mildly sensitizing the rectal lining to trigger a strong, natural expulsion urge. The typical response time lands between 15 and 60 minutes. Suppositories sit on the shelf of practically every pharmacy without a prescription and are considered one of the safest routes, even for individuals juggling multiple chronic health conditions, since their absorption into the bloodstream is negligible. Insert the suppository, roll onto your left side for several minutes to let it melt fully, and actively try to suppress the initial urge for at least a quarter of an hour to let the medication achieve its maximum softening effect. Let us now unpack the behaviors that dig the hole deeper, even when they seem perfectly logical at first glance. The initial trap is violent straining. We already spotlighted the Valsalva threat. It is not simply ineffective against a dehydrated mass, it poses a genuine danger to your heart muscle and cerebral vessels. The second pitfall is repeatedly postponing the body's elimination signal. When you habitually override the urge, the rectum gradually adapts to being distended, and its alarm system grows quieter, making future episodes more likely. The third misstep is failing to match increased fiber with increased fluids. If you load up on bran muffins or psyllium powder while your water intake stays flat, you manufacture a larger, denser obstruction, escalating the problem you set out to solve. The fourth error is executing a sudden, aggressive fiber ramp. Your intestinal ecosystem demands a gradual adaptation curve. Spread the increase over a week or two, not a single weekend. The fifth sabotage move is perching on the toilet for marathon sessions exceeding 10 minutes. This habit elevates pressure on the delicate veins surrounding the anus and inflates the risk of hemorrhoid formation. The sixth danger is the reckless, unmonitored use of enemas and stimulant laxatives without a clinician's roadmap. The bowel can become physiologically dependent on artificial stimulation, eventually losing its native ability to function independently over time. And the seventh, a topic rarely whispered about out loud. Because the entire subject carries a heavy cloak of shame, people delay a straightforward conversation with their doctor for months, sometimes stretching into years, experimenting with increasingly aggressive home concoctions. The longer this silent struggle drags on, the more complicated the eventual fix becomes. Reaching out early is almost always simpler and faster than waiting until the walls close in. Now, the most critical piece. Kitchen and over-the-counter remedies frequently break the cycle, but specific red-line scenarios demand you stop self-treating and seek immediate professional intervention. Get medical help right away if you have gone 3 or more full days without a bowel movement despite faithfully applying the steps on this list. You develop sharp or escalating abdominal agony. You begin throwing up. A fever ignites. You spot blood streaking the stool or on the wiping tissue, particularly if it resembles dark coffee grounds. Your abdomen balloons into a taut, rigid drum. You completely cease passing any gas. This constellation can signal an intestinal obstruction. Or you have observed a steady, unintentional drop in body weight over recent weeks or months. If the impaction is severe and home maneuvers fail to produce results within a day or two, a doctor or nurse can safely and expertly clear it manually in a sterile clinical environment. This is a routine, dignified medical procedure, and there is absolutely no reason to feel shame about it. Do not attempt this manual removal by yourself at home. And if you have crossed the 50-year mark and never scheduled a colonoscopy, this moment offers a strong prompt to ask your physician whether the timing is right. So let us tie the threads together. Stool lodging in the final exit is profoundly unpleasant, sometimes frightening, yet in the vast majority of cases, entirely manageable. Beginning with timed hydration and toilet alignment, progressing through breath control and targeted abdominal massage, and, when necessary, deploying glycerin suppositories or magnesium hydroxide, most people discover real release within a single day. But the deeper victory extends beyond breaking today's dam. It lies in ensuring the crisis returns as infrequently as humanly possible. Weave these 4 habits into your fabric slowly, adopting just 1 fresh habit per week. Sip water consistently across the full arc of the day, not only when your mouth feels dry. Move your body at least a little every single day without exception. Never mute your body's bathroom signal when it chimes. Try to reserve a calm, unhurried window for elimination, ideally 20 to 30 minutes after finishing breakfast, and gradually weave more colorful vegetables, whole fruits, and intact grains into your plate. So here is my closing question for you. What truly takes more effort? Managing the physical discomfort we just outlined, or gathering the courage to speak 3 honest sentences to your doctor about it? Let me know in the comments section. Your organism knows precisely how to sustain itself. It just occasionally requires the correct type of gentle support. If this guide brought you clarity, please take a second to like this video. It helps my channel reach the exact people who need this calm, practical advice. Look after your body, honor its signals, and never feel shy about looping in your doctor. For them, this is an entirely unremarkable slice of their daily routine, and for you, it could be the opening chapter of a vastly easier, more peaceful